A white paper bag sits on a pharmacy counter in Ohio. Inside is a 30-day supply of a brand-name diabetes tablet. The patient taps a card and pays a copay. The pharmacist sees a reimbursement post to the store. A health plan, hours later, books a different amount as the cost of the claim. Months after that, a manufacturer may wire a rebate that never appears on the receipt. 4 numbers, 1 pill. And between those numbers sits a firm most patients cannot name. That firm is a pharmacy benefit manager. Health plans hire these intermediaries to control prescription spending. The assignment sounds clean. Build a pharmacy network, process claims, bargain with drug makers. Steer patients toward cheaper medicines when a cheaper medicine exists. On the contract, the PBM is a cost control vendor. In the payment chain, it becomes a gate. It can collect manufacturer rebates tied to formulary rank. It can keep a spread between what a plan is billed and what a pharmacy is paid. It can own the mail-order pharmacy that fills the script or live inside the same corporate family as the insurer that signed the deal. Tools built to squeeze prices can become lines of profit.
This is the contradiction. Intermediaries hired to discipline drug costs can earn money from opaque rebates, from spread pricing, and from pharmacies they control. In July 2024, Federal Trade Commission staff released an interim report on prescription drug middlemen. The staff documented that the 6 largest U.S. pharmacy benefit managers handled more than 90% of prescriptions in 2023. It is a market fact about who stands between manufacturers, insurers, pharmacies, and patients. The same staff writing uses qualified language about incentives and potential effects. A rebate can reduce a plan's net drug spend. Nothing in the record says every PBM contract raises every patient's price. The mechanism is a stack of contracts that delay the true price of a medicine until after the tablet has already been swallowed. Why do health plans still hire the gate? And what happens when one firm writes the covered drug list, reimburses the pharmacy, and owns a pharmacy of its own?
The American prescription is not priced like a loaf of bread. It is priced like a claim. That difference is the historical blind spot. For most of the 20th century, a patient paid a drugstore and hoped insurance might reimburse later, or paid cash and asked for nothing. Hospital bills had their own labyrinth. Retail pills were smaller, more local, less engineered. Then coverage expanded. Employers added drug benefits. Public programs followed. Someone had to decide which pharmacies were in-network, which pills were preferred, and how a claim traveling at electronic speed would be adjudicated before the patient left the counter. Pharmacy benefit managers stepped into that gap first as processors. In the late 1960s and 1970s, the job looked clerical. Pay the claim, keep a file, take a fee. The more scripts a contractor could adjudicate, the more attractive it became to a plan that did not want to staff a national pharmacy desk. By the 1980s and 1990s, managed care had a new appetite. Mail-order pharmacies promised 90-day fills at a distance. Formularies ranked drugs. Preferred brands received a better copay.
Non-preferred brands sat behind prior authorization. Generic substitution became a policy, then a habit. The plan hired the manager because the plan could not cheaply do the work itself. A mid-size employer cannot negotiate a nationwide pharmacy contract. A regional insurer cannot easily run a rebate auction against a dozen manufacturers of cholesterol pills. The PBM sold scale. Scale meant a book of lives large enough that a drug maker would pay for access. Scale meant a network large enough that a local pharmacy would accept the reimbursement terms or lose the traffic. The hire was rational. It still is on that narrow logic. What most people miss is that the hire changed the object being priced. The patient sees a copay. The pharmacist sees a reimbursement. The plan sees a billed amount, and later a net amount after rebates. The manufacturer sees a list price, a discount, and a rebate obligation. Those are not 4 views of one price. They are 4 contracts that only sometimes meet.
The Government Accountability Office, in a 2024 report on selected states' regulation of pharmacy benefit managers, independently documented the job description that grew out of that history. PBMs administer prescription benefits. They negotiate rebates. They affect drug pricing. They use pharmacy reimbursement arrangements, including spread pricing. That is not an activist pamphlet.
It is a federal audit agency describing a market role that states had already begun to police. The rebate era did not arrive as a confession. It arrived as a bargaining tool. When 2 or 3 branded drugs compete inside a class, the maker of one brand can offer money back to the PBM or the plan in exchange for a better tier. A better tier means more volume. More volume justifies the rebate. The list price can stay high or even rise because the rebate is calculated from that list. A plan that is shown a large rebate can believe it won. A patient whose coinsurance is a percentage of the list can lose. A pharmacy that is paid from a different schedule may never see the rebate at all. The cost control function and the opacity function grew in the same soil.
Public insurance made the soil richer. Medicare Part D, launched in 2006, delivered tens of millions of beneficiaries into privately administered drug plans. Those plans leaned on PBMs for networks, formularies, and manufacturer deals. Medicaid managed care organizations did the same for many state beneficiaries. Self-funded employers, sitting under federal ERISA rules, signed contracts whose rebate language could run longer than the summary a worker received at open enrollment. Each new book of lives increased the value of the intermediary. Each new book of lives also increased the cost of firing one. By the 2010s, mergers had stacked the contractors into a shorter list. A claims processor bought a mail-order pharmacy, an insurer bought a PBM, a drugstore chain bought a PBM, then an insurer. Vertical combination was sold as efficiency. One corporate family could align the plan, the benefit manager, and the store. Critics heard something else. The agent and the principal had started sharing a balance sheet. The later survey of state regulation exists because legislatures had already heard independent pharmacies, employers, and sometimes their own Medicaid agencies complain that the reimbursement math no longer looked like a simple fee for processing. The contradiction at the counter does not come from nowhere. It is the afterimage of a 50-year outsourcing decision. Plans hired managers to control costs because claims are numerous and manufacturers are few. The managers became the market. And once a manager can move a formulary, a network, and a rebate check, the original hire is no longer just a back-office convenience. It is the price system. Follow the firms, not the slogans. A pharmacy benefit manager does not need a storefront on Main Street. It needs a book of covered lives and the right to decide which medicines those lives will find easy to fill. The large ones sit inside familiar corporate families. CVS Health houses Caremark beside a national drugstore chain, and after the Aetna combination, a major insurer. Cigna houses Express Scripts under the Evernorth banner. United Health Group houses OptumRx beside a vast physician, data, and mail-order apparatus. Beside them stand other national and mid-tier managers that, together with the giants, make up the shortlist that now processes almost the entire country's retail scripts. The names change with mergers. The job does not. Each firm is paid to be an agent. The principal is supposed to be the health plan, the employer, the union trust, or the public program that hired it. The agent's advertised virtue is leverage. One negotiator facing Pfizer or Novo Nordisk can extract a larger concession than 1,000 scattered plans. One network contract can put a rural independent pharmacy and a 24-hour chain on the same electronic rail.
That is the motive the sales deck leads with, and it is not imaginary. Drug makers do pay for access. Pharmacies do accept terms they would reject from a single county plan. Then look at the second motive, the one that does not fit on the cover slide. If compensation includes a share of manufacturer rebates, the agent has a reason to care about list price and rebate size, not only about the net cost the patient will feel. If compensation includes spread pricing, the agent has a reason to care about the gap between the plan invoice and the pharmacy check. If the agent owns a mail order or specialty pharmacy, it has a reason to steer fills toward its own counter. If the agent and the insurer share a parent, the parent can win even when one subsidiary's bargain looks like another subsidiary's loss. None of this requires a cartoon villain. It requires a contract that does not force every dollar of advantage back to the principal. The life or death decisions are quieter than a boardroom explosion. A formulary committee ranks a new GLP-1 against an older analog. A network team sets a generic effective rate that a small pharmacy cannot meet without buying inventory at a loss.
A specialty pharmacy rule says a cancer oral must ship from the company's own warehouse, not from the clinic down the street.
A rebate guarantee promised to an employer can be met only if a high-list brand stays preferred. Each choice is defensible in isolation. Together, they decide which medicines millions of Americans receive, which pharmacies fill them, and how costs are distributed among patients, sponsors, manufacturers, and stores. Independent pharmacists describe the squeeze as existential. Plan sponsors describe the quarterly rebate check as the only proof they still have a bargainer. Manufacturers describe the formulary as a toll booth they cannot drive around. Patients describe a prior authorization letter that arrives after the first dose has already failed. All of them are talking to the same intermediary. The psychology is not mystery. It is ordinary commercial hunger operating inside an unusually opaque market. The obsession is volume with control. The hidden motive is to remain the unavoidable crossing point. Once you are the crossing point, firing you is a system conversion, not a vendor swap.
The chain lights up when a pharmacist types the claim. In that second, the PBM switch reads the member, the drug, the day's supply, the pharmacy's network status, and the formulary tier. An approval or a rejection returns before the bag is stapled. That speed is the service plan's bought. Everything contested sits in the numbers the switch does not show the patient. Start with the rebate, because it is the cleanest illustration of a cost control tool that can invert. A manufacturer wants preferred placement. The PBM, speaking for a book of lives, can grant a preferred tier, a lighter prior authorization, or the exclusion of a rival. In exchange, the manufacturer promises a rebate, often a percentage of list price, sometimes with volume hurdles. The plan may receive all of that rebate, most of it, or a guaranteed dollar amount with the manager keeping the rest. Contracts vary. The variation is the point. If the visible win is a large rebate against a high list, the manager and the sponsor can both claim savings, while a patient paying co-insurance on the list still faces a large number at the register. Staff analysis at the FTC has described how those incentives can favor high-list, high-rebate products over lower-list rivals. The language is about incentives and potential effects, not a finding that every preferred brand is a ripoff. The wound is subtler. The ranking that was supposed to chase the lowest net price can chase the largest check. Now, the formulary itself. It looks like a clinical document. In practice, it is also a commercial instrument. Utilization management, step therapy, quantity limits, prior authorization can be medicine. It can also be leverage. A drug that fails to pay may find itself behind extra paperwork. A drug that pays may find a smoother path. Doctors experience this as friction. Manufacturers experience it as a second price. Patients experience it as delay. The GAO's description of PBM influence over drug pricing sits here, in the everyday power to make one molecule easy and another molecule hard, without ever writing a prescription. Spread pricing is plainer arithmetic. The manager bills the plan one amount for a generic fill and reimburses the pharmacy a smaller amount. The difference is the spread.
In some commercial contracts, the spread is replaced by a transparent administrative fee. In others, especially in certain Medicaid managed care arrangements examined by states in the late 2010s, the spread became a political object because public money was on both sides of the gap. Ohio's auditor, in 2018, reported that spread pricing in the state's Medicaid pharmacy program had extracted tens of millions of dollars that did not reach pharmacies. Other states commissioned their own looks. The GAO later treated spread pricing as one of the reimbursement arrangements states were trying to regulate, not as a myth and not as a universal law of every private contract. Some managers moved clients toward pass-through pricing. Some clients still bought spread deals because the administrative fee looked smaller on a slide. The plan that does not see the pharmacy's check cannot know which story it is in. Pharmacy networks multiply the same logic. A narrow network can produce a deeper discount. It can also push volume toward affiliated stores and mail-order hubs.
Direct and indirect remuneration fees, clawed back after the fill, made independent pharmacies argue that the posted reimbursement was not the real reimbursement. Federal and state rules chipped at gag clauses that once stopped a pharmacist from telling a patient that cash might be cheaper than the copay. Those fights are not folklore. They are documented attempts to reopen a price that the switch had already closed.
Vertical integration is where the incentives stop being adjacent and start sharing a parent. When the PBM, the insurer, and the pharmacy live in one family, steering is no longer a side contract. It is an internal transfer. Mail order and specialty pharmacies inside the family can be designated as mandatory. Independent stores can be offered terms that make specialty or 90-day fills uneconomic. The affiliated insurer can treat the affiliated manager as a partner rather than as a vendor to be threatened. FTC staff, in that interim work, mapped concentration together with these structural ties and described possible harms to pharmacies and to competition.
The staff did not convert the map into a verdict that every vertically integrated fill is more expensive for every member. A family can eliminate double markups. A family can also hide them. Watch the conflict accumulate rather than resolve. A manufacturer raises list price and enlarges the rebate to keep the tier. A plan reports a larger rebate and calls it a win. A patient with a deductible measured against list pays more in January. A rural pharmacy fills the same claim at a reimbursement below acquisition cost and discontinues the drug. The member is then directed to a mail-order warehouse owned by the manager. Each actor can produce a spreadsheet that proves rationality. The spreadsheets do not add to one price. States tried to write the missing price into law. They demanded rebate pass-through. They banned or limited spread in Medicaid. They required pharmacy manuals to be disclosed. They restricted gag clauses. They argued about ERISA preemption when the employer was self-funded and the state wanted to reach the contract anyway.
The GAO's 2024 review of selected states exists because the cost control contractor had become an object of regulation, the way a utility becomes an object of regulation after it stops looking like a mere vendor. Federal attention arrived on a parallel track. The interim staff report did not end the business. It named the concentration, the vertical ties, the formulary influence, and the pharmacy effects with the caution of an unfinished investigation. The climax is not a single raid. It is a daily adjudication in which one switch still decides coverage for a country. Idealism says the intermediary exists to beat down manufacturers and pharmacies on behalf of patients. Reality says the intermediary is paid in ways that can reward list inflation, spread, and self-dealing, even while some clients receive genuine net savings. Ambition built the Book of Lives. Constraint is the political and legal effort to force the book to show its work. Barriers break in pieces. A state law here, a contract rewrite there, a staff report with qualified verbs. The wound stays open because the original hire still makes operational sense. Plans still need someone to run the rail.
The rail still belongs to a handful of firms, and the patient at the counter still cannot see which of the four numbers is the real one. An economy that cannot show a price on time will invent priests to interpret the delay. Pharmacy benefit managers are those priests, hired in good faith to read a market that no single employer or county clinic could read alone. The larger principle is not that middlemen are parasites. The larger principle is that an agent paid on the fog can learn to need the fog. Rebates, spreads, network clawbacks, and in-house pharmacies are not four scandals. They are four ways a delayed price can be harvested before it becomes public. This channel's subject lives in that harvest. Strange incentives look irrational only until the contract is opened. A manufacturer feeding a rebate off a high list is not confused. A plan accepting a guarantee instead of a window into the pharmacy check is not confused. A manager filling its own mail order bag is not confused. Each is answering the instrument in front of it. The weirdness is the instrument, a payment chain that lets several parties win their private game while the social object, the cost of a swallowed tablet, remains unreconciled. Customers feel the unreconciled object as a copay that refuses to match the advertised discount. Workers behind the counter feel it as a reimbursement that arrives, then shrinks. Suppliers feel it as a toll for formulary entry. Competitors among pharmacies feel it as a network they cannot refuse and cannot survive. An entire industry of drug coverage now runs through a crossing so concentrated that changing managers is less like switching a contractor and more like changing the rails under a moving train. That is a system consequence, not a piece of consumer trivia about coupons.
The aftertaste is the qualification that honest work has to keep in the mouth. Staff findings about incentives are not a proof that every member overpaid. State regulation of reimbursement is not a proof that every spread was theft. Cost control remains a real function. Claims still have to be paid in a second. Manufacturers still have to be bargained with. The documentary fact is narrower and harder. The same architecture that buys leverage also buys the chance to sell the fog back to the people who hired you to clear it. Picture the bag again, without restaging the receipt. Somewhere a tablet has already dissolved. Somewhere a rebate has not yet posted.
Somewhere, a pharmacy ledger and a plan ledger still disagree. The price is traveling. It always was. The haunting question is not whether America will keep hiring the gatekeepers. It is this: if the true cost of a medicine can be known only after it is consumed, who exactly is the buyer?